Hi everyone and welcome. While people are still coming in, I'm going to go over a few housekeeping items. Please make sure to mute your lines. We will have time for questions and answers at the end. If you have a question during the presentation, please type it in the chat box on the right-hand side of your screen. Please close any other applications or windows that you're not using to conserve bandwidth. This webinar will be recorded and uploaded to our website next week. I'm excited to introduce our presenters today. Denise Octavia Smith is the founding executive director of the National Association of Community Health Workers. Mrs. Smith is a visiting scholar at the Harvard Medical School Center for Primary Care program in Global Primary Care and Social Change, an Aspen Institute Healthy Communities Fellow, and a Robert Wood Johnson Culture of Health leader. As a woman of African descent, a community health worker, certified patient navigator, and a survivor of a rare chronic disease, Denise is the co-founder of the Community-Based Workforce Alliance and the Vaccine Equity Cooperative. She collaborates on national initiatives to advance CHW leadership, enrolls in the COVID-19 response and community recovery, pursue racial equity, and improve clinical and community integration to address the social determinants of health. She envisions a culture of health where individuals have self-determination and dignity, where communities meaningfully contribute to a system design and governance, and where societies eliminate structural barriers to well-being. Our second presenter is Dr. Ashley Wennerstrom, who is an associate professor at the Center for Healthcare Value and Equity at the LSU Health Sciences Center, New Orleans, where she directs the Louisiana Community Health Worker Institute. She has been a proud ally of the community health worker workforce for over a dozen years. She focuses on CHW workforce development and policy, and she conducts community academic partnered research focused on prompting health equity. Her work has been funded by the CDC, NIH, HRSA, and PCORI. Ashley is a Robert Wood Johnson Interdisciplinary Research Leaders Fellow. She currently co-leads the Louisiana CHW Workforce Coalition. Ashley is the co-founder of the Louisiana Community Health Outreach Network and is a founding board member of the National Association of Community Health Workers. So with that, I'm going to turn over the presenters. I am going to share the presentation really quick. So I just added a slide here, just make sure we're muting our lines, and just a quick reminder that the webinar will be recorded and uploaded to our website. So Denise, whenever you are ready.
Okay, perfect. Can you hear me all right?
Yes.
Wonderful. Well, greetings, everyone. Thank you so much for the kind introduction. Thank you for the invitation to present. And I want to say a special thanks to Ashley Wennerstrom, who, among so many other things, is a colleague, friend, and a founding board member of NCEAS. And I've had the great pleasure to share a couple of these platforms with her. And I just appreciate and thank her so much for inviting me. I also want to apologize. I'm not on video today because I'm driving, but I have my headset on, and I'm really happy to be in a space to have this conversation. I'm going to take the next 15 minutes or so to go through these slides. Next slide, please. The slide before you should say the long road to equity in the United States. And I have been, in the last several, beginning my conversations about the roles of community health workers and grounding that conversation in the United States context and a history of structural racism and inequity, which very much impacts the identity, the qualities, the geographies from which CHWs emanate, as well as where we are providing the majority of our services and who we share lived experience with and who we provide services to. This slide is a super high-level history lesson in the United States. So there's lots of gaps here. But whether we are talking about the treaties, in many instances crafted and then broken with indigenous tribal nations, of which the United States has over 530. Those treaties which guaranteed access to education and health services, but yet we see among our tribal nations some of the worst health outcomes and health status across all indicators. Whether we are looking at the landmark study of W.E.B. Du Bois, who examined the impact of migration of former slaves and their children who were free, coming to the north, moving to cities, and the impact that racism and segregation and low income, little access to health care was having upon their health care status, the social drivers of well-being, and the poor access they had to a variety of services. Whether we are talking about the impact of, I should say, the passing of the Medicare-Medicaid Act and its striving to begin to address significant inequities among low-income populations, populations that are vulnerable for a variety of reasons, but yet we find that we have many states here in the U.S. That do not have Medicaid expansion as we've come to know it through the Affordable Care Act, and tens of millions of people continue to languish without insurance or are underinsured. And we can go on to the Heckler report that helped to craft and found the Office of Minority Health that basically said this report should help to launch an assault on healthcare disparities. But we still, since that time, some 40 years later, are still finding glaring disparities among those who are marginalized by race, by sexual identity, by income, and in many instances, by geography. Up until the 2011 report by Robert Wood Johnson called Healthcare's Blind Side, where over about 1,400 medical providers, primary care providers, said that they wish that they could write prescriptions for safe housing, for nutritious food, but experienced barriers because of payment infrastructures, codes, and scope of practice and the like that prevented them from moving upstream to address the social determinants, which of course were impacting downstream preventable chronic disease. We are on a journey to equity, and we have a long way to go here in the U.S. Next slide, please. This next slide just really tries to bring home the incredible diversity of our nation and in so many instances how that became structural in racist policies that relocated millions of people. Here I'm speaking about tribal members from the Southeast, and I'm showing here Andrew Jackson's impact of that work. The selling of generations of families of enslaved Africans, and in some instances of enslaved indigenous individuals as well. The migration to the U.S. resulting from wars and famines and economic stress on nations and regions of the globe, and all that results in terms of the way in which we have systems of health, mental health, social service delivery that were really not built for all of these populations. They were not built in the sense of respecting these populations and in really trying to provide a high quality, culturally competent, accessible, and affordable service. Next slide, please. What has come out of this incredible diversity of our nation over these 100 years are community health workers. And here you should be seeing a slide There are two women from the Navajo Nation. They're wearing masks. These are elders, but they are also community health representatives. There are many others you see on the slide who are bringing together, syncretizing, if you will, traditional health beliefs, cultural and spiritual practices. In other words, thinking about health holistically, grounding health in place, in culture, in language, but also addressing the real needs, the everyday needs of managing chronic disease, infections, sickness, the birthing of babies, recovering from surgeries, from cancers. Community health workers today are engaging in a variety of ways in community, and I'm going to talk a little bit more about that. Next slide, please. So here you'll see this slide, which just says, who are community health workers in the United States today? And it is very much an umbrella term that the National Association of Community Health Workers and many hundreds of organizations, public and private, large and small, use across the country to bring together a very diverse workforce with dozens of titles, including CHRs, community health representatives, promotores, peers, outreach workers, and many others. We are on the front lines of public health, and in many instances, we are partnering with primary care, with nurses, with doctors, with social workers and social service providers, with psychologists, with clinicians, to help address both downstream services as well as helping to inform and hopefully transform upstream the way that we deliver services and care in the United States. We are improving cultural competence of service delivery, improving clinical, behavioral, and social service access, and really wanting to bring rigor and high quality to overall system performances. In many instances, because of our lived experience, we are survivors of cancer. We are persons living with HIV. We are persons who've experienced homelessness. We come from immigrant and refugee communities. We are those who leverage our lived experience to engender deep trust with the communities where we serve, because these are also communities often where we live. Next slide, please. So here is just a little bit of a window into who CHWs are. I'm just drawing here on data from the National Association of Community Health Workers. As you can see, CHWs are working in many different areas, in health education, conducting home visits, chronic disease and health system navigation, as well as coordinating a variety of different services. Our areas of expertise are also varied, from working, again, downstream with different gender-specific health needs and working with special populations, or working in maternal and child health, but also working upstream around housing, basic needs, immigration, civic engagement, social welfare, and economic opportunity. Next slide, please. It is very much the case with NACHWA members and nationally that the majority of community health workers are not found in our state and local health departments as employees of health plans or hospitals or FQHCs, clinics, but the majority of CHWs are working through community-based organizations, small and large, and nonprofits. And that's important when we think about how we recognize them as a profession, how we protect them in the midst of the pandemic and beyond, making sure they have access to the vaccine, access to PPE, access to self-care supports, but also how we partner with CHWs, whether or not they are hired directly into organizations, or whether or not this is an org-to-org, an institution-to-institution partnership, and CHWs remain in the community to maintain and deepen that trust and deliver those services through those sorts of agreements. Next slide, please. the slide that should be before you right now, I cannot see the screen, should just say that we are a precarious workforce. And I think I've said that in so many words, but I definitely want to emphasize that here, that it is because of our lived experience that we are survivors of many of the sort of experiences of marginalization, of racial bias, of poverty, of other sort of failures of safety net systems or opportunities for advancement, that we can then come back into these systems and bridge them and navigate them and help to coordinate communications and data to build trust across these systems and silos. And of course, we're working in areas that are often very under-resourced, and oftentimes those communities are not appreciated or centered for the assets that they bring and the insights that they bring to transform service. Next slide, please. So despite, 60 or so years of evidence of CHW effectiveness, and you see on the right side of your screen a brief that NCEAS put together with the Association of State and Territorial Health Officials on CHW effectiveness. We have a classification in the Department of Labor. The Patient-Centered Outcomes Research Institute has spent the last 10 years and was just reauthorized to continue its portfolio of work over 76 comparative effectiveness research projects, all with CHW interventions. And of course, the map that you see before you is from the National Association of State Health Policy, where you see dozens and dozens of states moving forward and having difficult but promising, important conversations about state scope of work, about CHW legislation, about workforce practices and policies, about payment, and the ways in which CHWs can be integrated into systems, but also in ways in which they can advance as a profession through their state associations, through trainings that CHWs both develop and lead in their states. Next slide, please. One of the pillars of the work that NCEAS does as we seek to unify our very diverse profession is to elevate those competencies and qualities and skills that are unique to our profession. In many instances, folks are still sort of grasping how is it that this profession, number one, could be around for so long but yet be so unknown and not formalized. And part of that is our deep-rootedness in community and cultural tradition, as I mentioned earlier. But also, how can we have a unique scope of work? How is it that we cannot be duplicative of others on a care team? And so here you see a very important document. It's just a slice of the work that was done out of the Core Consensus Project, a national multi-year project with CHWs and promotores, community health representatives from tribal nations, and many allies representing many different public and private institutions to clarify not only what those core competencies are, but how you as an employer might assess for these competencies, qualities, and skills as you seek to recruit, partner with, and integrate CHWs into your practice. Next slide, please. As I wrap up, I may be over my time, so someone can feel free to interrupt me. But this next slide just talks about NCEAS implementation during COVID-19. I came on as the first ED of the National Association in November 2019, and Ashley Wennerstrom and I were actually on our very first webinar, March 11th, I believe it was, and we were talking about her work in certification and conversations that she had with states, the data that she had gathered, and the chat began blowing up with conversation about COVID-19 and the pandemic. And so NCEAS got to work both connecting with existing membership, growing our membership, and expanding our partnership and the platforms where we could amplify CHW roles. What you're seeing here is a health affairs blog that Ashley and I wrote together to strengthen the public health response to COVID-19. We need community health workers, because it was not the case that during the early months of the pandemic, CHWs were not being partnered with, being asked to serve on advisories, task forces, to help communities craft their language, their messaging, their response strategies, but quite the opposite. CHWs from our membership were being laid off from federally qualified health centers, hospitals, and even many nonprofits had to close their doors. And so these CHWs were at once disconnected from the communities they serve, but also were really disrespected as a profession that were bringing deep trust and knowledge of who was homebound, of who was food insecure, of who was going to be evicted, who did not have internet access. These are the things that in some ways were pivotal to see whether or not a family could really sustain themselves while they were shut in, while they were self-isolating, while they were quarantining, or while they were just simply out of work during the pandemic. Next slide, please. All of these slides also are hyperlinked, so if you see a picture, oftentimes they're hyperlinked to sort of allow you to gather and sort of click on those resources later, and hopefully they'll be beneficial to you. So here I'm just going to briefly say that NCEAS has had the good fortune to partner with many organizations, including the Centers for Disease Control, Partners in Health, Last Mile Health, the Rockefeller Foundation, dozens of CHW networks who were doing incredible work, training their members in COVID, helping them connect with response teams and task forces, delivering diapers, picking up groceries, just incredible and unprecedented response. And of course, we know that with the incoming administration, we finally had a national strategy around COVID response that expressly included and prioritized a community-based workforce and community health workers in particular as key to the Biden-Harris COVID response strategy. Next slide, please. So as I've said, before the pandemic, CHWs were addressing the social drivers of well-being. During the pandemic, we became critical to bridging these siloed sectors. Very important, and of course, all of us are aware of what those social determinants are, and that up to 80% of what impacts the person's health happens outside of a doctor's office, outside of a prescription or a clinical treatment. So it is really important that we strengthen both the knowledge for future primary care and health professionals, their knowledge of CHW roles, their knowledge of our history, of our qualities, of our orientation to public health and our frontline work so that you can partner. Next slide, please. Here I'm just sharing one of my colleagues out of NYU, Nadia Islam, released this paper not too long ago on examples in ways that CHWs were responding to the social determinants of health when they were in New York City during the pandemic. So I won't read over this slide, but this is a deeper dive than we have time to sort of cover here. I just wanted to give you this one article. There are so many others, and when you read her brief, you'll also have a chance to sort of draw on some of the research that she's provided. But our impact on the SDOH is myriad. Next slide, please. We continue to this day, sometimes formally, sometimes informally, to help immigrant and refugee populations navigate what are brand new healthcare systems, primary care, urgent care, emergency departments, and how to ensure that we are getting the services we need. We are doing home visits and checking on those who are living with diabetes, have high blood pressure, high cholesterol, we're immunizing populations, and although that's not a widely delivered service for CHWs in the United States, globally it's far more common, and I think that CHWs here should also be involved. I think we all can say that we need an all-hands-on-deck approach when it comes to discussions about both adult and youth immunizations and prevention in general. And of course, we're delivering health education, and we're delivering a variety of basic needs. And this tradition goes back several decades, and there's only one picture here that is of a black and white photo. And what you're looking at is a picture of Mary Bassett. Mary Bassett at this time was a primary care provider, but also was a member of the Black Panther Party. And many do not automatically make the connection between the Black Panther Party and the history of community health workers. But here you see her at one of the over 60 free clinics that sprang up across the country, testing for sickle cell. The Black Panthers were also testing mold in people's homes and helping elders get through communities that were unsafe, helping to deliver what was the first and then became a national free breakfast program. So there are so many instances where communities have lifted up solutions, not always widely known or adopted. Next slide, please. I want to thank you for your patience as I round out these slides. During the pandemic, NACHWA was lifting up the ways in which CHWs were responding to racism and social justice. Many of you heard of the sharp uptick and really not surprising community violence, both verbal and physical, that was impacting Asian American and Pacific Islander communities because of the way that the virus was stigmatized. NACHWA, we partnered with a few organizations in the United States to lift up the Stop AAPI Hate, and also to talk about ways CHWs can help the organizations that they work with to provide a much more respectful and friendlier service to AAPHI communities. Next slide, please. CHWs are, from the time in December when the vaccines were first coming online until today, nearly 9 months later, we are addressing historic mistrust and systemic racism. We are going door to door and talking to many folks who are saying, it seems like systems are caring about us for the first time. There are many people who don't have a primary care provider. There are many folks who don't have a regular doctor, who are not connected to health systems, who still predominantly use the emergency room because of lack of health insurance, or perhaps lack of health insurance or health literacy. And so CHWs continue to try and make meaningful connections to increase access and awareness and administration of the vaccine. Next slide, and I think there are two more, and then I am finished. Finally, I just want to offer that during these last 9 months, NACHWA has had a chance to partner with the Association for Clinicians for the Underserved and many other organizations to help develop a checklist. If you have community health workers that are on your care team and are looking to adapt their roles or services, we provided some guidance there. And also we came together, NACHWA helped to found the Community-Based Workforce Alliance, where many CHWs as well as doulas, promotores are represented. And we talked about this playbook that we are now offering to public and private institutions, local health departments, to help them really integrate CHWs and advance their partnership in an authentic way. And then the last slide is just announcing that in February of 2021, NACHWA released, with the help of Ashley, as she's a co-leader of our policy committee, a national policy platform. It is imperative that we have allies and partners, advocates from all walks of life who are going to recognize CHWs as a profession, who are going to help us to sustain our work, respect, protect, and authentically partner with this profession. So I look forward to the discussion. I want to thank you again for the odd way that I'm presenting today, and I hope this presentation is meaningful and inspires some dialogue. Thank you so much.
All right. Well, thanks so much, Denise. That was incredible. I always really enjoy presenting with Denise, and she's always a very tough act to follow, but really appreciate all that you shared, Denise, about the history of the CHW workforce and all the incredible work that CHWs have been doing in response to the pandemic. I can say as a Nashua board member, when we selected Denise as our candidate, we were very excited about her joining the organization, but we could not have possibly imagined the incredible work and just how much success she would have in such a short amount of time under such difficult circumstances. So she's really an incredible leader. So with that, I just wanted to say a little bit about sort of what's next for the community health worker workforce in the U.S. as we continue through the pandemic and hopefully beyond one of these days. But just wanted to highlight a few major pieces of funding that have come out in recent months that will really sort of affect the workforce and grow the workforce. First and foremost, with the CARES Act and the American Rescue Plan this year, there have been billions of dollars in funding for community-based workforce, including CHWs. I can't really emphasize enough how massively important that is for all the reasons that Denise just discussed, but also because given the disparities that we've already had in health, we've already needed this funding, and we've never seen a huge influx of money in the same way for the community health worker workforce. So this is very exciting. Through the CDC, also, there has been some funding that's come down already through their 2103 grants. These are non-competitive, but these are specifically focused on addressing COVID disparities. There were 107 grantees in all 50 states that have received funds through that mechanism. The Office of Minority Health recently put out a request and has made funding available focused on advancing health literacy to enhance equitable community response to COVID-19. And there have been grantees in 70 cities or counties. And I can say I'm very happy that New Orleans is one of those. And then there are several different pending funding announcements right now. One is the CDC's 2109 announcement, CHWs for COVID response and resilient communities. That funding, when it is announced, will be going to state health departments primarily and tribal health departments as well to fund CHW programs. Sort of a sister mechanism to that is the CDC's 2110 grant, which will provide technical assistance and evaluation for all of the 2109 awardees. And then HRSA also has recently put out some funding for community-based workforce related to COVID-19 vaccine outreach. So all of the numbers and all the technicalities don't matter tremendously, but what I want folks to walk away with is this understanding that we have a huge influx of funding for community health workers right now that's related to COVID response. And so we can move on to the next slide. But it really raises a lot of important questions for the workforce. The first is related to sustainability. So, or the first in my mind anyway, we're going to have, thousands of CHWs hired across the country under all of these mechanisms, which is wonderful news. However, these are short-term grant opportunities that will be ending within a couple, 3 years. And so it really raises the question of, well, what happens to this workforce once that funding goes away? And as someone who's worked in the CHW sort of field for about 15 years now, the question that we're always asking ourselves is how can we create sustainable financing for CHW positions? There is a lot of movement. I won't get into great details on this because we just don't have the time for it and we can't go into all the nuances. But there has been a lot of movement at the state level towards integrating CHWs into structures where they can be supported by Medicaid. And there are a lot of different mechanisms to do that. And we're also seeing more and more Medicaid managed care organizations starting to hire community health workers, either in some cases in a few states because they're required to do so by their managed care contracts, and in some cases just because they know that CHWs will contribute to improving health outcomes among their members. So we're seeing more and more of that, but we've got to consider as a field, what are we going to do when these new funding position. When the new funding runs out in a few years, we're going to have all these folks, and so we're going to have to figure out if there are creative ways that we can sustainably finance these tremendously important positions. And then just a few other thoughts that I want to leave folks with before we go into our discussion. Hopefully folks have questions. I know that Denise and I will be very happy to answer as many of them as we can. One of the things that we talk about a lot in the CHW field is this notion of nothing about us without us. What we've really seen in the last several years as community health workers have continued to be sort of recognized for their importance in improving health outcomes and reducing healthcare costs, is that there's a lot of new interest in the field, and a lot of stakeholders in public health and healthcare are very interested in working with CHWs, but also sort of controlling how the field will move. And so sometimes we're seeing situations where folks who are in academic settings or in policy settings and health departments and in hospitals are starting to make decisions about how the CHW workforce should be developed without involving community health workers in those decisions. So for those of you who are already working with CHWs or who are interested in doing so in the future, just really encourage you to remember that phrase, nothing about us without us, which comes from the disability rights movement, and really focuses on the importance of always involving CHWs in all decisions that are going to affect their workforce. And really in many cases as allies, sort of taking a back seat and making sure that we elevate CHW's voices so that they are able to make decisions about what is best for them and their workforce. With that, I've really encouraged folks to support and partner with local, state, regional, and national networks. Of course, Denise just did a fantastic job talking about the work that the National Association of CHWs has been doing, but also want folks to be aware that there are also local, state, and regional CHW associations. There is a list of those on the NACHWA website if you're not familiar with the ones that may be in your area, but in most states, there is some sort of CHW organization, so I encourage folks to reach out to them, get to know the CHWs in your area and learn how you can collaborate with them. And then finally, if you are interested in moving forward again and working with CHWs in some new way, whether that may be in terms of developing specific interventions or thinking about training or thinking about just policy related to CHWs, whatever you're thinking about doing, probably someone has done something similar before. NACHWA has recently assembled a fantastic document resource center that has all kinds of information on everything from resources for training, specific interventions, policy work that has gone on, and certainly lots of great resources related to CHW financing. So just encourage folks to take a look at that so that you can have support from previous work and learn from the great work that's been done, and also from the mistakes that many of us, myself included, have certainly made along the way. So that's all for me. We can go to the next slide, which just has my contact information. I love talking about community health workers. It is my job. It's the best thing I get to do. I love working directly with community health workers. And I should give a quick shout out to my colleague, Catherine Haywood, who is the director of the Louisiana Community Health Outreach Network, which is our CHW association here. She's my partner in crime in all things in Louisiana. But in any case, I put my contact information here in case there's any questions that you all may have afterwards. By all means, feel free to reach out. I'm happy to chat with anyone about CHWs. But with that, I think we can just go ahead and open it up for questions. I see one in the chat that it's a long one. I'll try to read it out. This question comes from Ryan Smith. With the many areas CHWs work in outside of the immediate health sector, are there other sectors that have shown more need, acceptance, and the financial willingness to support our CHW workforce? And is there a way for us to focus on grants going forward to be written with us /CHWs in them to help sustain our work and need? As we all know, organizations will always do what the dollars tell them to do. So a campaign for us to better inform the sources of the dollars instead of the locations using the dollars. Okay, complex question and a great one. Denise, do you want to take a shot at that? And then I might have some thoughts.
Yes, it was a pretty big question. Just read the first part again, because I think I want to respond to that, which is
Sure.
Other sectors and their sustainability, maybe.
Yeah, the many areas CHWs work in outside of the immediate health sector, are there other sectors that have shown more need acceptance and the financial willingness to support our CHW workforce?
Yeah, so I won't go sort of hard and fast on the idea of a sector, but I will say this. For several decades, and one of the slides that I shared really elevates the extent to which CHWs have been on the front lines of chronic disease response. So, of course, the Centers for Disease Control and its heart disease and stroke, diabetes, HIV/AIDS, these are all areas where CHWs have been at the forefront. You know, while the funding mechanisms remain grants, and so those are 1 to 2 years or perhaps a cooperative agreement, but these are still grant funded. It's not the same sort of continuous reimbursement or recognition of CHWs as a profession as we would like. There has been a lot of, first of all, need, and also a good deal of clarification on how currently the federal government and states want to fund that. Another area that has had lots of activity has been in the area of peers, and in particular around peers in recovery. The Substance Abuse and Mental Health Services Administration and many state-level associations have also, services administrations have also really centered the peer model. And there is a lot of legislation moving forward to recognize peers as professionals in states. I hope that answers the first part of the question. And Ashley, the second part, and maybe you can start and I'll come in later.
Sure, I'll read the second part. Is there a way to focus on grants going forward to be written with us /CHWs in them to help sustain our work and need? As we all know, organizations will always do what the dollars tell them to do. So essentially a campaign for us to better inform the sources of the dollars instead of the locations using the dollars is how it was written.
Yeah, and I like that, if I'm hearing that correctly, because we do need better funding models. So in some instances, we need funding models. And a lot of states are exploring right now Medicaid and CHW's roles in Medicaid. As Ashley said, you know, a lot of our work at NCEAS is in ensuring and advocating for a holistic description and scope of CHW roles. Oftentimes, and no disrespect to folks who sort of done this before, but oftentimes CHWs are hired to deliver flyers, to go door to door. And so, you know, the system, the employer that is hiring a CHW to do something like that, someone with lived experience, someone who has been trained, mentored by other CHWs, is not reaping the full benefit, all of the assets that CHW can bring to the care team. Of course, there are always bright spots across the country, but you're right, working upstream is really important, and during the pandemic, NCEAS has tried to do our best with our partners and allies to speak directly to HRSA, CDC, whomever might be looking at funding announcements to talk about how they can embed these values, these qualities, these approaches, best practice into the NOFO itself. In particular, with the American Rescue Plan funding, hundreds of thousands of CHWs could potentially be hired in these 6-month, 1-year, 2-year grants. And we want to make sure that they have the right sort of workload or caseload. We want to be sure that they receive appropriate supervision. We want to make sure that authentic CHWs are being hired. I mean, there are many components of this interaction and this partnership. So when we have a chance to impact the NOFO itself, the funding announcement, the model, that's really the best way to do it, because we can better disseminate what we know works.
Thanks, Denise. Yeah, and I would just add that a lot of the funding sources that we're talking about right now clearly are at the federal level, but keep in mind there's also a lot of state level funding that can support CHWs, and especially through public health departments and things like that. So it does sort of, to me, highlight the importance of CHWs also being organized within any given state, and certainly appealing to state legislatures for additional funding and support for their work. What other questions do folks have? Let's see, we have a comment. All right, getting a thumbs up from Ryan Smith. Thank you. Let's see, we have a question. When educating healthcare providers on collaboration and care roles, community health workers are often excluded. Great articles were pointed out during the delivery of this lovely presentation, but I was wondering if you all know about work that focuses on incorporating CHWs into interprofessional education. Yeah, Denise and I both actually have a little bit of experience with that. Denise, do you want to go first? I can talk a little bit about mine.
Yeah, sure. I have been a CHW for a couple of decades, mostly here in Connecticut. And I've had, I was first hired through the AHEX. So if folks are familiar with the area health education centers, often they have an office, or at least one of the offices in the state is at an academic medical center or a nursing school or public health school. And so my AHEC, which focused a lot on HIV/AIDS, had a lot of interaction with the University of Connecticut. Over time, I started to become much more involved, first with their migrant farm worker program, making sure that we could provide health services, language translation, and social needs to those who were coming in to work in the tobacco fields in Connecticut, and then on to their urban service track and their interdisciplinary care team, where you have mental health, nursing, primary care, and dental students working and learning together. Eventually, a lot of this came under a health disparity sort of certificate program that the University of Connecticut was coordinating. But what I think is important is that the students had an opportunity to actually first of all, to have conversations about the social determinants of health, the social drivers of well-being. Not saying that this is the case everywhere, but many of the first and second year students that I interacted with really had not experienced a lot of the marginalization that the clients in the health centers, or where they were doing their cliques, their demonstration projects, they didn't have the same lived experience. And so stopping to talk about case examples, to do a sort of journey map and talk about how challenging it is for a single mother with 4 children who's on Medicaid, who's had to move 2 or 3 times because she can't afford the rent, whose children are going to different schools because of the magnet school program, and they're going to this food pantry once a week and this soup kitchen every weekend, to really make this plain and help people to understand how is it that the CHW comes in. It's not that we're superheroes, that's not it, but we often know where people are going. We can begin to have these conversations and say, I've been there, or I can help you, or I know someone, let's work through this. So it's very important to ground primary care practice in an acknowledgement, a respect, and a prioritization of the social determinants of health. When I worked with the students up at UConn, we also talked about what the future of healthcare is, and it very much is primary care providers having networks and referrals and relationships to social needs, not just screening for social needs, but actually responding and perhaps being paid against the achievement of some of those indicators or outcomes. So it is very important that that network is established, and CHWs are critical there.
Thanks, Denise. Yeah, I'll give just one other quick example. So in my previous role, I worked at Tulane School of Medicine for many years, and for 6 years, well, developed and directed a community health clerkship that was focused on social determinants of health, and it was primarily third and fourth year medical students. So what we did was we developed a completely non-clinical rotation, which some of the students loved and some were horrified by. But rather than spending time in clinic, each student was assigned to work at some sort of community agency that addressed a social determinant of health. And many of those agencies had community health workers on staff. And so the types of agencies we're talking about are social service agencies. I've sent folks to the public defender's office, just all kinds of different community health organizations. So the med students were actually going out and understanding how health is addressed in many, many, many different ways that are non-clinical, and in many cases working directly with CHWs. So that's just one example. Certainly there are others, but I do think slowly but surely, community health workers are starting to be recognized more as members of healthcare teams. But I think because it isn't sort of a standard practice of IPE at this point, it really speaks to the importance of allies, those of us who happen to be based at academic medical centers, speaking up and saying, hey, when are we going to start to incorporate CHWs into our curricula and make sure that students are learning about them and how to work closely with them and value the incredible expertise that they bring to a health professional team. Let's see, what other questions can we answer? Seeing a comment in the chat, currently housed within a school of nursing. However, it seems a bit difficult to explain to the community health nursing faculty how we can work together. Yes, I think that is definitely a challenge that many face. I don't have any easy answers to that one, but it's certainly a challenge. Other thoughts, questions?
I just want to say one thing. Thank you so much for both of you for presenting. I'm going to drop the evaluation link in the chat box as well. So if you guys, as we're finishing up, if anyone would like to complete that, be helpful. Thank you. And if we have any more questions, we can hang on for a couple of minutes.
Oh, I saw one that was just entered into chat. Have you found a better method to measure the value of CHW work to use in organizations? Thanks for that question, Ryan. It's a really good one. I can start, and then certainly Denise may have some additional thoughts as well. I think this is one of the biggest challenges that the community health worker world has faced, is that because CHWs are usually working in a specific intervention, either they're working at a CBO or they're working with a primary care clinic, or maybe they're working at a Medicaid managed care organization, the way that their quote unquote value or contribution is measured is often very different. Sometimes it's measured in terms of a specific health outcome. So, can we achieve blood pressure control, or can we reduce A1C levels for diabetes? Sometimes it's measured in terms of health behavior. Can we get people to start checking their blood pressure regularly, or can we get people to start engaging in cancer screening? And then in some cases, CHW's contributions are measured exclusively in terms of a financial return on investment, which I think is a very bad idea, which I won't go into in great detail today. But point being, there's no one single consistent measure. And this is something that we've struggled with. The good news, there is a wonderful project going on right now that's funded by the CDC called the Community Health Worker Common Indicators Project, often called just the CI project, being run by a wonderful team of folks, both CHWs and allies working together, who've created sort of a national network that's collaborating to develop a set of standard indicators, and has just begun piloting those indicators. And the idea is that these indicators should be measures that folks could use across the country, regardless of setting, regardless of type of intervention, to help measure CHW success and outcome. So I would say we're on our way to getting there. Not there yet, but I think there is a lot of hope, and it's very encouraging to me that the CDC is supporting this type of effort, and that it's being done really strategically and thoughtfully. Denise, please feel free to jump in if you have other anything else to add to that specifically, or anything else regarding measurement.
Well, the only thing that I think I would say is that it's the most important is for the patient, for the individual, the family, to feel that their needs are met and that they can now have the capacity, the resources, the information, the treatment to achieve or at least pursue their own health and well-being goals. That's really the most important. So, sometimes I speak as a CHW. I'm also a survivor of a rare chronic disease, and, very much hope that some of the work that PCORI is doing to center the patient voice across the research continuum, some of the work that is being done to reframe and broaden or sort of, broaden the perspective of what we mean by measurement and indicators of success. I think that's very important, and CHWs are advocates for patients in a clinical environment of individuals and families in a community environment, so they want to contribute to the design and the development of those metrics, not simply have them placed upon them. And I think the last thing that I would say as you're thinking about integration and we're thinking about measurement is, oftentimes CHWs are brought onto the care team, but there is not equity in resource or agency in access. So I'll give just one quick example. CHW access to the data that they often collect is, fairly non-existent. It's one thing to say, we really want you to target this community, go out and gather this data or complete this intake when people come through the door. It's another to sit and analyze the data and think about what does that data mean and what are the strategies, what is the data telling us about what we should do next. And oftentimes CHWs are not part of that discussion. When you don't have that sort of intelligence, the intelligence from the data, the intelligence from working as part of the care team, your strategies can be hindered for lack of information, for lack of collaboration, or for lack of agency. If CHWs are not, don't have the same freedom to make referrals, right, to add to an electronic health record, to read an electronic health record, right, to understand what data others are collecting in their health practices as appropriate through HIPAA, et cetera, you can hinder the very thing that you're trying to accomplish. So I think it should be holistic. I think it should be grounded in the needs of the patient. And I think it should be respectful of CHWs as a profession, and again, well-resource them and appropriately equip them so that they can work at their highest scope and be effective.
Thanks, Denise. Well, it looks like we are just about out of time. Thank you everyone so much for the opportunity to chat with you today. I hope this was helpful. Feel free to reach out to me anytime if there's anything that I can be helpful with. And just really appreciate everyone's time. And thank you, Denise, so much for your contributions, for being willing to present with me again. And Claire, thank you very much for organizing all of this.
Yes, thank you both so much. Like I said, the evaluation is in the chat box.
Thanks very much, Ashley and Claire.
Thank you, Denise. And I will work on getting this online. Hopefully at the end of the day, otherwise at the end of the week. And I will email everyone, and it will be on Twitter as well. Thank you.